Okay, great. Thanks, Jade. All right. Hi, everyone. Good afternoon. My name is Hesam. I'm an ophthalmologist. I work at the Lions Eye Institute just next door. And I'm kind of amazed by this attendance. I was expecting just like one person in the room because of COVID. So thanks for coming. Have you guys started any of you had your eye clinic sessions yet? Not yet. Have you got your times and places? Yeah, good. So is this your first ophthalmology session? Am I correct in saying that? Yep, good. Who's had a chance to look at any of the videos? Hands up. So you got the email about the various videos. Great. Okay. Very good. So I'll just introduce Jesse and Noor. Jesse and Noor are our clinical tutors this year. You'll be seeing them a bit later on in the clinical skills workshop and in some tutorials later this term. Has anyone done eyes before? Just out of interest? Any ophthalmology exposure? Nothing. Okay, good. Starting from scratch. All right, so a bit of housekeeping to start with. Let me just get some water. Is this working? No. There we go. Okay. So guys, you're going to get 2 lectures from me this term. That's the second one there in February. Let's see if I can turn these lights down a bit. Just bear with me. It's better for the ophthalmic images, which we'll be looking at a bit later. So second lecture in February, 2 tutorials next week, next Wednesday. So they're 2 different case-based tutorials. The group will be split into 2. You'll do 1 shoot and then you'll swap over. You've got your clinical skills workshop today, and then you've got the clinic sessions at the hospitals. And we've got the videos, as you know, online. So they're your various teaching and resources that you'll get this term. Assessment-wise, you've got your end of term exam on the 18th of March. That's back here. And there's picture-based questions and then MCQs. And then if everything goes ahead as expected, you'll have an end of year OSCE like we did last year. We don't know the date for that yet, but it's a single ophthalmology station. It's a clinical station. Obviously, it's an OSCE. And there'll be a trigger, often with some images. We'll test at least 1 clinical skill, and then we'll have a discussion about diagnosis and management. And I will, once we get into the second part of today's session, I'll teach like an OSCE sort of structure, so you'll get an idea. Supplementary exams, you won't need them. No one here will need them. If you just attend everything, you'll be fine. Attend and listen. Okay, so this is the first part of a lecture on acute visual disturbance. You've seen the introduction to ophthalmology. You've seen a red eye video. This is now about people presenting with visual disturbance. And today I'm going to look at painless loss of vision, okay? So you can have painful loss of vision and painless loss of vision. This is people turning up with, not with red eyes, with white eyes, and with painless loss of vision. We'll go through, we'll just touch on the curriculum before we get started, and then I'll go through the approach to painless loss of vision, history and exam. We'll then go on to the actual conditions that I want you guys to know, and hopefully there'll be a bit of time for question and answer, although we are running behind already. Okay, so there's your curriculum. It looks busy, and I guess it kind of is. The number of diagnoses has been reduced, believe it or not, from somewhere in the 60s to somewhere in the 40s now. Hard to get it less than this, to be honest, but they are clustered in, I hope, somewhat intuitive ways. So for example, this whole cluster is ocular trauma. So a foreign body, a chemical injury, a scratch on the surface, fractured your orbit. And all of these clusters are related somehow. So if you look at this one, for example, this is all optic nerve pathology, okay? Giant cell arteritis, ischemic optic neuropathy. So if you approach it that way and split it into they're presenting for a red eye or they're presenting for loss of vision, that gives you a framework, if you like, to being able to figure out what to do next and what it could be, to have a sensible list of differentials. Today, we're going to be looking at these 4 conditions, okay? These are causes of acute painless loss of vision, plus macular degeneration, and I'm not seeing vitreous hemorrhage on there, but that, or retinal detachment. Can you guys see that anywhere? Am I missing it? Oh, right. Yeah, retinal detachment, just make that detachment / vitreous hemorrhage, okay? They're the conditions that we're going to be looking at. Can't read my own work. That's great. Okay, so what are the 6 main conditions, okay? Here we go. Retinal artery occlusion, retinal vein occlusion, so-called wet age-related macular degeneration, retinal detachment, vitreous hemorrhage, and diabetic macular edema. That was on there as well. These are the 6 that I need you guys to know, and I'll show you the level of detail that you need to know. Take note that they're all retinal problems. They're all back of the eye posterior segment, where you don't tend to feel pain unless there's been trauma. There are other causes of painless loss of vision, sometimes painful. These are the optic neuropathies that I indicated earlier on the Venn diagram. And then there are other visual disturbances, which is not necessarily loss of vision, but you might get double vision from a cranial nerve palsy, or diplopia, or ptosis, and they have their own sort of workups. The ones on the right of the screen, I'm not going to cover today. Okay, we're going to focus on these 6 conditions here today. These will be covered in another lecture. So, you know, what does the history tell us? I think 80% of your diagnosis should come from the history, as Tally and O'Connor says. You should be able to get down to 2 or 3 differentials just from the history. And I'm going to show you how. This is the approach. Before we do that, any thoughts on that photo there, normal or abnormal? I think I heard someone say abnormal. That's correct. What's the obvious abnormality? When you don't have to know the technical language, what's unusual about this picture? Well, firstly, what is it a picture of? Anyone know? Give you 3 options. It's the eyelid, it's the eyelash, or it's the fundus. Great, okay. Good start. What's the abnormal thing? You may not have seen many fundus photos, I accept that. All this red stuff, normal or abnormal? Good. What's red in the body? Blood vessels and blood. So this is a fundus that's full of blood from a central retinal vein occlusion, okay? So we'll talk more about vein occlusions in a moment, but I want you to get used to seeing these pictures and quickly being able to say, is it normal or abnormal? I'll show you a normal picture later on so you get familiar with what normal looks like. Okay, so look, the first thing to start with, in a trigger or in real life, you're going to have the age of the patient, and the age quickly should guide you to the most common causes of painless loss of vision. In elderly patients, so 70 plus, it's going to be age-related macular degeneration or giant cell arteritis. They're the 2 that you need to think about first, which is not to say that it'll be that every time, but probability-wise, that's what you have to think. Middle-aged people get retinal arterial occlusions or retinal vein occlusions, okay? They also get diabetic macular edema and vitreous hemorrhages, right? So age-wise, that's what happens to middle-aged people with diabetes. That would be the prompt. Here's a 55-year-old with diabetes. You already need to be thinking diabetic macular edema or vitreous hemorrhage from diabetes. That's how I want you to think. Retinal detachments, RD, and vitreous hemorrhages can also happen in younger years and in later years, but they present with specific symptoms that the other ones don't. And we'll talk more about that in a moment. What about timing, the timing of the onset of symptoms? Well, vascular events in the body tend to be instantaneous. You block off an artery, you get ischemia, you get an infarction within seconds to minutes, right? So if it's instantaneous, rapid, acute history, then you're thinking it's a blocked vein, it's a blocked artery, or they've just had a bleed into the vitreous, the jelly of the eyeball. Okay, they're the 3 to think about. Retinal detachments, RD, they tend to present over a period of hours. I'm giving you the most common scenario. Obviously, there are exceptions to all of these, but detachments tend to present over a period of hours, and they have very specific symptoms that I'll talk about in a moment. Something that presents over days, 2 to 3 days, more likely to be macular degeneration or diabetic macular edema, okay? So this is how you use the onset now, again, to narrow your list of differentials. As far as which side is affected, is it unilateral or bilateral? Acute painless loss of vision tends to be unilateral almost always. It's very unusual to get bilateral sudden loss of vision. If you've got a case of bilateral loss of vision, you need to be thinking about a central cause. So an occipital lobe infarction, posterior communicating artery within the brain, okay? If it knocks out both eyes, it's more likely to be a central cause, whereas ocular causes tend to be unilateral. Okay, second fundus picture, normal or abnormal? What's an obvious area of abnormality? I'm going to give you two choices. This patch here next to the optic disc, or this one that's further away from the disc. Which one do you think is abnormal? Closer or further from the disc? Anyone know what all this yellow stuff is? Not a bad guess at all. It could be drusen. Drusen look a bit differently. It look a bit different. I'll show you pictures of drusen in a moment. But these are hard exudates, okay? So this is lipid exudation, lipid leaking out of damaged blood vessels in people with diabetes. That's the most common cause. Now, this is your optic disc, which means that this is your macula. If you've got lipid around your macula, hard exudate, means fluids leaking into the macula. So this person is going to have diabetic macular edema, okay? So that's what a picture of diabetic macular edema looks like, all right? Let's keep going with the history. So we've already said this is painless loss of vision and there was no preceding trauma. Your trauma case is going to be obvious. It's going to be someone in a car accident, or it's going to be someone who's doing some activity and something hit their eye, okay? That's not what we're talking about today. Now, something that happens often in an OSCE and in real life is you'll get given a patient with loss of vision, partial loss of vision, whatever, something like that, blurred vision. And it's important to characterize how the vision was lost and what it's like, particularly if it's central vision or peripheral vision, okay? And this is somewhere where people often seem to fall down in OSCEs. They just forget to ask about what the onset of the loss of vision was like. So please remember that in the OSCE setting and in real life. Patient comes in, oh, I can't see out of my right eye. Tell me more. How did it start? Was it the center of your vision, or did it come on from the side or the top or the bottom? Okay, they're the kind of questions you need to be asking. If it's central loss of vision, it's most likely going to be a macular problem, right? And on that list of 6 conditions, there's only 2 which immediately affect the macula. The others can, but the 2 which immediately affect the macula are macular degeneration and diabetic macular edema, okay? So elderly person, unilateral, central blurring of vision, you have to be thinking macular degeneration first and giant cell arteritis second. I'll talk more about giant cell arteritis in another lecture, but that's an important condition to always think of in elderly patients because that can become bilateral. It's unilateral, quickly becomes bilateral if it's not treated. So that's central loss of vision. If you've got progressive peripheral loss of vision with a curtain, with the word curtain being used, curtain is a buzzword for retinal detachment, okay? So, oh, what's the loss of vision like? Oh, it's like a curtain coming across my vision. You have to say retinal detachment, okay? And often it starts from the periphery and then it progresses towards the center. That's a typical retinal detachment patient. Now, vitreous hemorrhage can do that too. Vitreous hemorrhage can kind of start anywhere. It can start in the center, it can start peripherally, but they may well say, oh, it's like a red haze and then it slowly got bigger over a couple of days. That's how vitreous hemorrhage behaves. And number one cause for vitreous hemorrhage, diabetes. So that will be the scenario that we give you. Diabetic patient, unilateral blurring of vision over 2 days. What was the loss of vision like? Oh, it's kind of a reddish color. You have to say vitreous hemorrhage, okay? And then we talk about management. I am giving you all the answers right now, so there's no excuse, okay? This is how you have to think. All right, associated symptoms, really important, okay? So macular causes, okay, central macular, often patients will describe distortion. Distortion means a straight line starts to look wavy, right? So you're looking at a door frame or a window frame and there's a kink or a bend in the middle of it. That's not normal. And so distortion, think macular. Flashes and floaters, number one, think retinal detachment. And number two, think vitreous hemorrhage, okay? Anything that pulls on the retina causes flashes and can cause floaters. If you push hard enough on your own eye, I don't recommend this, but if you do, you'll see some flashes because it stimulates the retina to think it's seeing light, okay? We call that an entoptic phenomenon. So flashing lights, retinal detachment, or vitreous hemorrhage if it's the right scenario. And then giant cell arteritis, scalp pain, jaw claudication. They're the two sort of classic symptoms. There are others, but you have to ask about those in an elderly patient. We had an OSCE last year that was a retinal arterial occlusion case. Okay, this was last year's OSCE, and too many people didn't ask about giant cell arteritis. And it was an elderly patient, 70 plus. So that's a problem because if you miss GCA, the patient's blind bilaterally 2, 3, 4 days later. So always think about that in older patients. Okay, so clearly abnormal. Bottom half or top half abnormal? Who says top? No one. Who says bottom? Good. Because it's pale, okay? So normal retina should look orangish. Bottom looks whitish cream. So this is a branch artery occlusion, okay? Inferior branch retinal artery occlusion. Finishing up on history now. So in the ocular history, so you ask the patient, any eye problems in the past? Yes, I'm short-sighted, which means they're myopic, okay, like me. If you're short-sighted, you're at an increased risk of getting retinal detachments. So that's part of the retinal detachment scenario. And it's pretty much, ocular-wise, it's the only one that's relevant for this set of conditions to you guys. Past medical history, diabetes we've talked about, diabetic macular edema, vitreous hemorrhage, ischemic heart disease, AF, cerebrovascular disease, okay, so vascular paths. They're blocking off arteries and veins elsewhere. Therefore, you think blocked artery or vein in the eye, okay? And then the systemic association, the most common systemic association with GCA is polymyalgia rheumatica, so a rheumatological condition. It might be another rheumatological condition that we give you. We might give you rheumatoid or we might give you SLE, but they're the systemic associations with giant cell. Finally, the causes that tend to run in families, ARMD has a familial association and detachment can have a familial association as well. So has anyone in your family lost vision? Yes, my dad suddenly lost vision in one eye as well. And then you can explore that a bit further. So that's the full sort of history. And by now you should more or less have your answer in most cases, right? Exam-wise, look, I'm not going to spend too much time on exam in this lecture because you're going to be doing it in the workshop just now. But to briefly summarize, they're the components of an ocular exam. And this is more or less what you have to do in everyone who comes in with an eye problem. So gross examination, anything obviously abnormal. Then the 5 components of an optic nerve exam. Then you want to look at them on the slit lamp. You do fluorescein staining if it's relevant, right? If there's no foreign body, the eye's comfortable, it's not a red eye, you don't necessarily need to do fluorescein staining. And then again, ocular motility if it's relevant. Motility is a good thing to do, you know, just to get into the habit of, because it's part of your neurology exam as well. As you know, we've got the videos online, which you may have already seen. Okay, so this is a normal fundus photo. I just want to get you oriented. Does anybody know how to pick right versus left eyes? Because you do need to know that. No volunteers. So the way to remember it is that the nerve, the optic nerve, which is the round yellow thing, is always closer to the nose, okay? So if the nerve is nasal and the person is facing you, when you look at a fundus photo, it's always the person looking at you. So which eye does that make this, if the nerve is on the nasal side? Yeah. So the nose is over there, person's looking at you this way, okay? So you start off by saying this is a fundus photo of the right eye. That's how you describe a picture. There's an approach to assessing the fundus. I'm not going to go through it now. We cover that in the fundoscopy video. I'm just going to give you the basic approach, which is to say, you want to see a yellow nerve with a distinct border between it and orange retinal tissue. And then you've got blood vessels running throughout the whole fundus, which are slightly darker red for veins and slightly lighter red for arteries, okay? And veins have a slightly higher caliber. They're a bit wider than arteries. That's how you distinguish artery and vein, okay? Artery slightly narrower, paler, vein slightly fatter and darker, right? All the tissue in between the retinal blood vessels should be orange. It's a bit of a deeper orange in the center here, which is the macula. Macula is the very center of the retina. It's lateral or temporal to the optic nerve. So you orient yourself. This is the right eye. The nose is over here. I'm going to go temporally. There's the macula. I know it's more darkly pigmented than the rest of the retina, so I know I'm in the right place. Nerve, macula, blood vessels, intervening retina. Okay. Anything in the intervening retina that is not orange or reddish, let's say, is not normal. And those things tend to be yellow, red, or black in color. Yellow, whitish, or black. Anything like that, your eye should go to that and you start to figure out what's going on here, like we did earlier with the yellow stuff, the hard exudate. Okay. So if you need to kind of imprint this picture, print it out in color and stick it on your toilet door so you always look at it when you're at home. And then you know what normal looks like and you can quickly do pattern recognition to pick an abnormal eye, okay? So, you know, if a student in an OSCE says, right fundus photo looks normal, the left one's clearly abnormal, they're like, you're halfway there already, rather than, you know, having to have it dragged out of you. All right, so this is something called an Amsler grid chart. It's a representation of a patient's visual field, basically. And this is what distortion looks like. So I talked about distortion earlier. Which part of the eye is involved when we talk about distortion? Which part do you immediately think of? Can you remember the two conditions? We talk about macula. One's got the word, well, they both have the word macula in there. Yes. And what's the other one? Diabetic macular edema. Okay. So you see this picture and you immediately go to those two conditions and wait for the rest of the triggers or the prompts. Now, we've got blood here in the center of the macula. Diabetes doesn't do this. Diabetes doesn't cause a big hemorrhage in the central macula. This is what wet or neovascular macular degeneration looks like. And these yellow things over here are drusen, okay? So you can see they are similar to the untrained eye to hard exudates, which you see in diabetes. But this is going to be an 80-year-old, let's say, who does not have diabetes. So you're therefore going to think wet age-related macular degeneration. Wet because there's blood, okay? Dry macular degeneration, there's no bleeding. So it's called wet because there's blood. So let's talk about wet, or also called it neovascular age-related macular degeneration. This is now one of the commonest treatments in Australia. So I do this every day, pretty much, which is to inject an agent into the eye. The eye's anesthetized, obviously, which temporarily stops the bleeding of these abnormal blood vessels, which grow in age-related macular degeneration. Okay, so this is where patients are going to end up. They're going to end up in front of an ophthalmologist with an anesthetized eye getting an injection. More about that in a moment, but macular degeneration in general, painless, acute, central, scotoma, and distortion. Okay, that's the presentation. And we've already said that it's elderly people. So your 40-year-old is not going to have this. The 40-year-old macular problem is going to be diabetes. Okay. What's the etiology? The outer retina essentially degenerates over time, and there's multiple layers that are involved. But for your purposes, the outer retina over time degenerates such that you get new blood vessels growing up into the retina where they don't belong. And these abnormal new blood vessels are prone to bleeding and leaking, okay? They leak fluid, which they shouldn't. They should be watertight, and they bleed. And this is how people lose vision. This is the commonest cause of vision loss in Australia still, okay? Even though there's treatments for it. Examination-wise, you're looking for drusen, and in an OSCE, we're going to give you someone with drusen and hemorrhage, much like the picture that I just showed you, okay? If it's just drusen with no signs of blood, they may still have distortion. That's dry macular degeneration. That's talked about in another lecture that's actually on YouTube as well. It's on chronic conditions. So dry macular degeneration can give you distortion, but it does not give you a rapid onset scotoma. That's wet macular degeneration. What's the management here? Same day referral to ophthalmology, okay? Smoking is the most important modifiable risk factor for macular degeneration. So if there are you ask about smoking. Had a guy today who's a smoker with AMD. AMD is the abbreviation. And the treatment is anti-vascular endothelial growth factor, VEGF, anti-VEGF. We call it anti-VEGF. So they're going to need injections into the eye initially once a month. So in the OSCE or in real life as a GP, you're going to see these patients. They're going to say, oh, doctor, what's the ophthalmologist going to do? Oh, they're going to put some treatment into your eye. Don't worry, it doesn't hurt. Or how often are they going to need to do it? Once a month to start with. It tends to become less frequent over time. Okay. How long will I need it for? Maybe indefinitely. Yeah, that's often the case. But often by the third, fourth, fifth year, instead of being 12 injections a year, which is what it might be in the first year, you're often down to 4. So it really does taper down as the macula stabilizes. And with early treatment, these guys do well. So the treatment works. Any questions about AMD? Anyone have any family members getting injections? Ask around, you might be surprised. It's so common. Okay. Okay, so here's that vein occlusion picture that I showed you earlier. If you had to pick one as being a central retinal vein occlusion and one as being a branch retinal vein occlusion, which one would you want to get you guys just to use your common sense and your intuition, right? So the branch, would you say, is the one on the right or the left? A few nods for the one on the right, which is correct, okay? So we talked about orange retinal tissue is normal. This looks pretty good to me. Do you agree? Clearly not normal up here. Red stuff and white stuff. These are cotton wool spots. Cotton wool spot is also seen in diabetes. It's a little area of inner retinal infarction, okay? Infarction of the inner retina, which is what's affected in vein occlusions. These are also cotton wool spots. Just the coloration in this picture is different to this one. So we've got a central vein occlusion and a branch vein occlusion, okay? Both of them involving the central macula. So you've got blood which does extend down to affect the macula. Therefore, vision is going to be affected. They're going to notice this. Here's a person with a central vein occlusion that has received laser treatment. That's what these little dots are. So we laser the back of the eye in some people with very bad vein occlusions. So what's the overview here? Painless acute loss or blurring of vision. It can involve the center, or it can just be a hemifield, superior or inferior. This branch picture that I showed you earlier, they're only going to have inferior hemifield loss, right? Because remember, if it's superior retina, that subserves the inferior visual field, right? It's just a bit of optics for you. It's always the opposite. So superior retina, inferior field, inferior retina, superior field. So this person's going to have an inferior visual field loss, but the center is going to be involved because it's affecting the macula. Okay. Middle-aged, okay, we talked about that. And they'll often have some vascular risk factors. So hypertension, hyperlipidemia, possibly diabetes. What's the etiology? It's sclerosis of an artery, most commonly. Sclerosis of an artery, hardening of an artery, which at the junction of an artery and a vein eventually leads to obstruction of the vein. Okay? So the artery compresses the vein, causes an obstruction. Hydrostatic pressure in the vein goes up, you block it off, blood's trying to return, it can't. And you get leakage of blood and other fluids into the retina. And if the macula swells up, you get central loss of vision. Examination-wise, well, you saw the hemorrhages. Look for veins in the affected area which look dilated relative to the veins in the unaffected area, if it's a branch vein occlusion. If it's a central vein occlusion, then they're all going to be dilated. So there you need to know what a normal picture looks like to be able to say, oh, those veins don't quite look right. They look dilated to me. And then just check to see if the macula is involved. Again, in this one, this is the right eye, nerve is nasal. There's the macula, lots of blood there. This person's going to have macular involvement. Okay. They may have a relative afferent pupillary defect, right? And we'll learn how to test for those today. A bad central retinal vein occlusion will give you a relative afferent pupillary defect. Cotton wool spots, you saw. The optic disc itself may be swollen. And as we said earlier, if it's the whole eye, think of a central vein occlusion, and if it's half, then think of a branch vein occlusion. Treatment-wise, there's systemic treatment and ocular treatment. The systemic treatment is management of the vascular risk factors, with hypertension being number one. That's what causes the arteriosclerosis. Again, this is an urgent referral, and anti-VEGF agents also work for vein occlusions. We also sometimes use steroid agents. Both of these are injected into the eye. So most vein occlusions will go on to need an injection of some sort. Some will also need laser treatment, like this one has had. So you don't need to know what agent they need. You don't need to know who needs laser and who doesn't. You just need to be able to identify what it is, identify that it's important that the underlying systemic risk factors get managed. What's your blood pressure? Has anyone checked it? Let's check it now, that sort of thing. That's what we do in clinic. And then be able to tell them you're probably going to need to have medications injected into your eye. You may also need some laser treatment. And again, most people, depending on the vein occlusion, you can have really good results. The key thing is early presentation. And so the most important thing to come out of this teaching for me as an ophthalmologist, because I know most of you guys want to end up becoming ophthalmologists. So the most important thing is early detection, diagnosis, and referral, because that probably determines visual outcome more than anything else. The later people present, the worse they tend to do. So your job is to know which conditions need urgent referral, and anytime you're in doubt, you pick up the phone and talk to an on-call ophthalmologist. And you can say that in the OSCE too. That's what you do in the real world. So if you're unsure, get advice. Okay, moving on to, you already know what that one is. That's a retinal artery occlusion, okay? So retinal vein occlusions give you blood. Retinal artery occlusions do not tend to give you, they can, but we won't give you an atypical case. We're going to give you a more typical case where you get infarction of the retina. And when the retina infarcts, it goes pale. So retinal pallor, paleness, whitish looking retina, is an arterial occlusion, okay? The center is often preserved because it has a secondary blood supply via what's called a cilioretinal artery. So the center relative to the rest of the retina looks red. This is called a cherry red spot. That's a buzzword for central retinal artery occlusion, okay? So you see this picture, you go, oh, that looks like a cherry red spot to me. I think this is a central retinal artery occlusion. And it will fit with the patient's history, which is middle-aged, vascular path, maybe has AF, hyperlipidemia, that sort of picture. Here's another branch artery occlusion, okay? So we've got a superior branch artery occlusion. It's a superior hemiretina that's affected. See these yellow dots here? They're emboli. So this person's got cholesterol emboli flicking off from somewhere, most commonly from the carotid artery, up to the ophthalmic artery and then into the retinal arterioles. So if you're thinking carotid disease, what are you going to do for them? What one test? How do you check carotid flow? Carotid ultrasound? Okay. So if I see this, I'm thinking carotid plaque. This person's got a carotid plaque and it's sending off microemboli to cause this artery occlusion. Okay, so once again, history, painless unilateral, blah, blah. It's all very similar. The distinguishing thing, actually, there's not much to distinguish this so far from a vein occlusion because they're a very similar subset of patients, right? They're vasculopaths and they're middle-aged. So in this person, it's probably going to be your assessment of the picture, which gives you the answer, okay? So blood, no blood. Retinal pallor, no retinal pallor. That's how you need to be thinking. The etiology is embolic most often, as I mentioned. Retinal pallor, we talked about cherry red spot, whole retina or hemiretina, similar to vein occlusions. They may also have an RAPD. So that doesn't distinguish it either. Vein occlusions don't have emboli. So if you see a pale retina, do track along the vessels. Remember the arteries are narrower. So that's the artery there. And that's the artery there, obviously. And look for emboli. If you can pick an embolus in an OSCE, that's gold star. Okay. But this is definitely a pattern recognition one. The workup is a stroke workup. Okay, so we immediately, so they need to come to us and then we refer them to stroke unit once we've confirmed the diagnosis. I should say, very important again, giant cell arteritis can cause retinal artery occlusions. So not embolic, inflammatory, right? Different etiology. So most often it's embolic, but always have GCA there as your differential. If they're 60 plus, definitely if they're 70 plus, you're going to do full blood count ESR and CRP. They're your screening tests for giant cell, as well as asking about jaw claudication, scalp tenderness, those things. So stroke workup, CT angio, carotid Doppler, transthoracic echo, ECG, plus or minus a Holter. And they may get thrombolized, depending on the center. Most places still don't thrombolize people. There's really no effective treatment for retinal artery occlusions, unfortunately. This is one of the worst presentations in ophthalmology because there's not much you can do. The vision loss is profound. But what we are doing is preventing them from having a stroke, having a heart attack, and dying. Because we know untreated retinal artery patients are at a much higher risk of sending an embolus off to their brain or their heart. They may already have a cardiac valvular problem and dying from a stroke or a heart attack. So this is an ophthalmic emergency where we're preventing loss of life more than loss of sight. Unfortunately, the sight's already been lost. It's different to a vein occlusion. You can recover sight in a vein occlusion, and you can recover sight in macular degeneration. Okay, so poor prognosis visually, unfortunately, but important, very, very important to manage nonetheless. All right, halfway through. 3 more conditions. Any questions so far? Happy enough? Okay. So I am just going to give you the answer here. Superior retina is abnormal. Looks like a brain. That's not normal. Retina shouldn't look like that. This down here looks normal. It's a bit out of focus, but that's because the photographer's focused on this area. This is bulging forwards. This is what a retinal detachment looks like. It is detached from the underlying choroid. That's the layer of tissue that's under the retina, and it's bulging forwards into the vitreous. On this side, again, you've got a superior retinal detachment. This is a tear in the retina, the visible tear, which is what causes the majority of retinal detachments. So you most often get a tear in the retina from the vitreous gel inside the eye, tugging on the retina, causing traction, causing a tear. Then vitreous fluid gets under that tear and the retina detaches. So it's like tearing a bit of wallpaper on the wall and then pouring some fluid into the hole that you've torn. And then the fluid acts to detach the whole wallpaper. And as the wallpaper falls off, the person's losing vision in that part of from that part of their retina. Okay. So what do you need to know here? There's the retina, the back of the eye. As it detaches, it can cause floaters. That traction on the retina we talked about earlier causes flashes. So that's the history. That's the vitreous, the jelly inside the eye. This is the vitreous detaching. So the vitreous detaches first. It pulls away from the retina. That's natural. That happens to everybody once they get to 60, 70 plus. More or less everyone gets a vitreous detachment. But sometimes a sticky part of the vitreous pulls on the retina, causes a tear that then becomes a detachment. Okay, that's the etiology. So the differentiating thing here on history is the curtain, the description of a curtain, and the flashes and floaters, and the fact that it's progressive. So most often peripheral and then progresses towards the center. Myopia is the important trigger, the important clue in the clinical trigger, okay? If you've been hit in the head, you know, car accident, that can bring it on as well. Diabetes is also a risk factor. So we talked about etiology. So you saw that corrugated looking retina, grey corrugated looking retina. And important to distinguish whether the macula is attached or detached, because we go back, the macula is responsible for high definition color vision, okay, central color vision. So as you're looking at me, you're all using your macula. Once the macula is detached, the visual prognosis becomes much, much worse. So it's important to know the macula on or macula off. Here, the macula is on. It's being threatened. You can see the detachment is progressing inferiorly, but it's still on. So you operate on this person quickly, you're going to save their sight. This person, probably macula on. There's the macula there. And there's the edge of the detachment. It's very close to being mac off. Hard to say for sure. You'd have to examine them closely. The vision itself is your clue. So if someone presents with 6/6 vision, flashes and floaters, if they've got 6/6, the macula is still on. If they've got 6/36 or hand movements, macula's off. It's still an urgent referral, but the advice to the person is, you know, more guarded. Not necessarily going to get great vision back, but it's better than not doing anything. You know, an untreated retinal detachment, you get total loss of vision, can end up becoming a painful blind eye. So they're all going to need surgery. That's the management. This is a surgical problem, not a medical problem. They're going to theatre. So you fast them, okay? That's what you do for them as a referrer. Okay, so flashes and floaters, but normal fundus and fields, and remember, you've got to check fields, they may well only have a vitreous detachment, although there might be a tear that hasn't turned into a retinal detachment yet. So flashes and floaters, vitreous detachment, plus or minus tear, plus or minus retinal detachment. These things all go together, right? The field loss, altitudinal means top, bottom. Okay, if you've got a detachment that's coming off, it affects that part of the field first. If the macula is involved, then it's total loss of field, okay? Management, prepare them for surgery. So pick up the phone, fast. You may be going to theatre today. If not today, then tomorrow. That's the normal management. There's different surgical approaches. You don't need to know them, but if you can remember vitrectomy as being the most common operation and a scleral buckle being less common, that's gold star stuff, but the main thing is to know that it's a surgical problem. Okay, so this is blood. This is what blood, not in the retina, but in the vitreous looks like. This is actually floating in front of the retina. And again, it's probably hard to appreciate if you haven't seen a lot of pictures, but this is a big blob of blood. It's different to the ones that we saw earlier for central retinal vein occlusion. There are parts of retina that almost look normal, and this is what a vitreous hemorrhage looks like, okay? So blood in the vitreous, this is what it looks like. This optic disc is not normal, right? I can't see a normal yellow contour all the way around. It's very fuzzy in this whole area. And these very fine blood vessels, if you look carefully, these very frilly blood vessels, they're not normal either. Okay, they shouldn't be there. Blood vessels emanating from the disc should be really clearly delineated. You should be able to see the margins really clearly. Whereas this looks like a frond of seaweed or something, right? That's not normal. This is neovascularization, new blood vessels, not from macular degeneration. They're in the macula. You can't actually see those blood vessels. These ones are visible. They're growing into the vitreous. This is diabetic retinopathy, bad diabetic retinopathy, which leads to neovascularization, most often at the optic disc, right? So your description when you see this picture is, it's actually hard to tell whether it's right or left, to be honest. I'd have to see a broader field. Abnormal blood vessels at the disc and vitreous hemorrhage. I know the patient's diabetic. That was in the trigger. I'm worried about what we call proliferative diabetic retinopathy, which is the most common cause of vitreous hemorrhages. There's a massive vitreous hemorrhage, right? Can't see any new vessels. So this is from a different cause, most commonly from a ruptured aneurysm. Don't worry about that diagnosis. Diabetes could equally cause a vitreous hemorrhage like this. And you can just see that it's a big clot of blood. And you can't see the retina in front of it. Therefore, it's pre-retinal. It's in front of the retina, which means it's in the vitreous. Okay? That's how you can differentiate. This is within the retina. This blood is within the retina. This blood's in front of the retina. You can sort of still make out retinal tissue, particularly around here, but you can't see anything here. It's just frank blood. That's how you pick a vitreous hemorrhage. So here are some causes. This is a vitreous hemorrhage caused by vitreous detachment. So earlier on, we talked about vitreous detachment, right? Which goes with retinal detachment. Vitreous detachment can also cause vitreous hemorrhage. As the vitreous detaches, which is a normal physiological thing, you can get shearing of a blood vessel, a retinal blood vessel, which then causes a vitreous hemorrhage. So it's a physiological event leading to a pathological presentation, let's say. So that would be flashes, floaters, and then I saw a reddish sort of cloud and it's obscuring part of my vision. That's a different etiology to diabetes, okay? Diabetes, you've got abnormal blood vessels which are prone to bleeding. Less to do with vitreous traction. So vitreous hemorrhage, just think two causes. Normal vitreous detachment plus hemorrhage, or bad diabetic eye disease. They're the two paths that you need to go down. History-wise, red haze, we talked about. Trauma can do this, but we won't give you a convoluted scenario, okay? We'll give you a common one. Myopia is a risk factor for vitreous and retinal detachment, so that's on the list. Etiology we've talked about. The field loss can be variable, can be central, can be peripheral. And the main thing here is the picture. You see a big blob of blood. Nothing else does that, really. That's a vitreous hemorrhage. And you may see some detached retina as well. You can get a detached retina and vitreous hemorrhage at the same time. Management-wise, yeah, assume they're going to go to theatre. Some vitreous hemorrhages will clear on their own, so they might not, but you need to plan for them going to theatre. Okay, so we're sending you to an ophthalmologist today. We're going to fast you from now. You may need an operation, and the rest is up to us. All right. If they're diabetic, then there's also the systemic management. Okay. So you've seen this picture already. This is your diabetic patient. The key thing with diabetes is that it's systemic, which means it's always a bilateral condition, can be asymmetric. Okay. So you've got left eye, right eye, and both of them have bad diabetic eye disease. Retinal vein occlusions, retinal artery occlusions almost always are unilateral. AMD, macular degeneration, always bilateral, but it's rarely acutely bilateral wet AMD. Usually one eye will become wet, the other one's still dry. But diabetes is the one condition that's always bilateral, certainly can be asymmetric. So you can have normal vision in one eye and the other eye getting slightly worse. Or you can have impaired vision in both eyes. So this is the one exception to that rule of always unilateral. Retinal detachments, vitreous hemorrhages, really unusual if they're bilateral, you know, without preceding trauma. So this is the one where you look at the fundus images and they both look really messy like these pictures do. You already know that they're diabetic. You've got to be thinking diabetic retinopathy, okay? So what is diabetic macular edema? Well, it's swelling of the central macula from damaged blood vessels caused by diabetes, caused by hyperglycemia, okay? That's what diabetic, and these are cross sections through the macula, okay? This is grossly swollen. You need to see normal ones, I suppose. This is more normal. So this is before treatment, this is after treatment. This is still not normal, this bottom one, but it's more normal than the top one. You can see that this is about twice as thick than this one. And that's what diabetic macular edema does. Commonest cause of vision loss in working age people, so 40 to 60. So super common. Painless central blurring, the clue is in the history, they're going to be diabetic. We talked about the etiology. The change in VA is very variable. They might come in, oh, I'm a bit blurry, 6/12, or they might be, I can't see, 6/0. It really just depends how late or early they're presenting. And what you're looking for is hemorrhages and exudates in the central macula, okay? Hemorrhages and exudates. Vein occlusions don't cause that. Artery occlusions don't cause that. The only one that you might confuse it with is wet macular degeneration, but this is not going to be a 70-year-old case, right? This will be a 45-year-old case with diabetes. So you have to say, I'm worried about diabetic macular edema. But they're the only two that kind of look similar. And none of them look anything like a retinal detachment or a vitreous hemorrhage. They look completely different. So they're the patterns that you're looking for. Management-wise, again, systemic and ocular. Systemic management of diabetes, as you'll learn in your endocrine term if you haven't already. Aiming for an HbA1c of 7 or less. That's what's been shown to slow the progression of diabetic retinopathy the most. And then they need to see an ophthalmologist within a week. This is more slowly progressive than the other conditions that we've talked about, but we're still not leaving them for months or even weeks. So within 1 week, they need to be in front of one of us. The earlier we treat them, the better. And again, similar to many of the other conditions, intravitreal injections, steroid or anti-VEGF, plus or minus laser. All right. The laser that we do is different to what we do for vein occlusions. You guys don't need to know that. And the regime of injections is different as well. But they're the two treatment modalities that you need to at least have heard of. Okay, so that's actually the last condition. Hopefully we've covered these things. Any burning questions at this point? Clear as mud? It's quite a lot, but if you just go through it a couple of times, you should be able to, as I said at the start, quickly be able to narrow your differentials down and then have something sensible to say about management. And in ophthalmology in general, management-wise, don't forget systemic management. Don't forget systemic history taking either. Again, this is something that happened in last year's OSCE. We had this person with a arterial occlusion and no one asked about cardiovascular history. And I think the person had AF or some other systemic problem. And I've picked up people who have blood pressures, systolic blood pressures over 200, diastolic over 100 from a first diagnosis of a retinal vascular problem. So that thing of being able to diagnose systemic disease through the eye does happen. And those people may well have gone on to stroke out or whatever if we hadn't checked their blood pressure in clinic. So history-wise and management-wise, don't forget systemic when you've got a patient with an eye problem. Okay, that's any questions can go there. This is the ophthalmology team. We'll see you at the workshop in about half an hour. And yeah, catch up with you then. Yes. The clinic is in E.